Good morning. I thought that this topic was something that would be appropriate for the audience here for general surgery because it is something that does come up quite frequently. And it, in fact, has come up on occasion here during different M&M discussions. So no disclosures, just thought I'd be official. My aims for this presentation are first to discuss the prevalence of solitary pulmonary nodules and its likelihood of malignancy, because that really is what we're trying to figure out here, is that in this number of CT scans that are being done on a daily basis with all of the different incidental nodules that are identified, what really is truly going to be malignant, what requires us to investigate further. Also, I wanted to review different radiologic criteria that predict the risk of malignancy, to summarize current guidelines for the evaluation and management of nodules, incidental nodules, to highlight the role of shared decision-making in the management of incidental pulmonary nodules, and also to discuss the development of a couple different novel approaches that aren't necessarily mainstream, but that are being used in trying to identify lung nodules further for our surgical evaluation. And of course, we can't bring up the topic of pulmonary nodules without discussing lung cancer. So just to make this a little bit more relevant, lung cancer is the most common cancer-related death in both men and women in the United States. It is the #1 cause of cancer deaths in women. And lung cancer causes more deaths than the next 3 most common cancers all combined: colon, breast, and pancreatic cancer. Just to review cancer statistics, and I think we've all probably seen this diagram on a number of occasions here in grand rounds and during different presentations. So just to start off with what a lung nodule definition is, it's not just a spot on the lung. It is a discrete radiologic lesion. It does have a definitive size, so it's anything less than 3 centimeters. Anything greater than 3 centimeters is usually considered a mass at that point. It's surrounded by completely normal lung, and a solitary pulmonary nodule is just that. There's no associated pleural effusion, enlarged lymph nodes, or atelectasis. More recently, different societies, radiologic societies especially, have identified subsets of the solitary pulmonary nodule, part solid nodule and ground glass nodule, that you might see when you come across different CT reports. These are hazy opacities of the lung, and like one such that you can see right here. And so there are different categories of these, and we'll talk further about different algorithms if those different entities are identified on a CT scan. As far as incidental findings of these lung nodules go, very few of them are seen on chest x-ray. You really need something a little bit bigger, but with CT scans being used on a regular basis, especially in the emergency department and also on screening exams, we definitely end up seeing a lot more, anywhere in the range of 8 to 51% of those undergoing low-dose CT screening. And I think that range in number really is because different groups are being screened at different times. So that's just a very large range. Specifically with a national lung screening trial, which was a national clinical study put on by the National Cancer Institute, it looked at, it compared 2 different groups, people who were screened with chest x-ray and people who were undergoing screening with low-dose CT scan. And this really was in high-risk patients, so it can't necessarily be translated specifically to the global incidental lung nodule findings, but I did find it interesting that 25% of the patients that were undergoing low-dose CT screening did have some form of incidental lung nodules. So lung nodules aren't always going to be lung cancer, but I have to say that I think if any of us told one of our patients, or if we had ourselves been told that we have a lung nodule, I think the first thing in all of our minds would be we have lung cancer, or that person might think they have lung cancer. But there are several other reasons that somebody may have a lung nodule. several different developmental causes, congenital causes, different infectious or inflammatory etiologies. And really, it would be the radiologist's job as well as our job to try to figure out what exactly is most important, trying to identify what exactly is cancer and what we have to do about it. So they also can be different forms of non-small cell cancer, small cell carcinoma, carcinoid tumors, and these are mainly the items or the etiologies of lung nodules that we would need to take action for. So I also wanted to, you might be thinking at this point, well, you know, we might find a lung nodule and they can be seen by a thoracic surgeon, a pulmonologist, their primary care doctor. But I have to just want to throw that out there that all of us are probably going to, in our training and career, going to be dealing with something where we are going to be dealing with a patient who has an incidental lung nodule, and what are we going to do about it? So just a few clinical scenarios that I'm sure you all have run into. I know I have. So 72-year-old male, non-smoking male driver involved in a high-speed motor vehicle collision with complaints of substernal chest pain. No bony or vascular trauma was identified on their PAN scan, but the radiologist did find a 2.1 centimeter spiculated nodule in the left upper lobe. I know I've run into this situation, and I'm sure some of you have as well. Additionally, for the general surgery folks, 45-year-old morbidly obese female with a past history of heavy tobacco use is undergoing a pre-op evaluation for gastric bypass. They present to the emergency department with acute onset shortness of breath, and a CT angio of the chest is done by the emergency department physicians to rule out a pulmonary embolus, but it shows a 5-millimeter subpleural nodule. And an additional clinical scenario that I'm sure some of you might find familiar, a 63-year-old male never smoker with a history of multiple abdominal surgeries presents with severe abdominal pain and bilious emesis. And they undergo a CT abdomen pelvis when they're in the emergency department or up on the floor. And it does identify a small bowel obstruction with a transition point, but in addition, they also describe a 1.9 centimeter nodule at the base of the right upper lobe. And these are just some clinical scenarios that I know I have either recently, in the last couple of years, been, privy to, or else been experienced during my training. So what do we do with this? This is pretty much the point of my presentation. So initially, you would have some sort of evaluation. And I think all of us in our minds already try to figure out the likelihood of whether somebody would have a cancer or not, based on your clinical judgment. Are they a smoker, non-smoker? Have they been exposed to different toxic fumes or chemicals, their age? I think we all just kind of naturally do that in the back of our heads, but we'll go over different risk predictive models in a moment. And then a matter of diagnosis, and then coming up with a management plan. And if it is determined to be cancer, is that patient really a candidate for either surgical intervention, or do they even have any desire to move forward with treatment? So I think that's a change in the recent past that's a little bit different than earlier times. And so throughout all of this, we would ultimately be able to establish a management plan for that patient. And all along the way, I think this is what interests me most about thoracic surgery, is that it is a coordinated, multidisciplinary effort. It's not just focused solely on the thoracic surgeon. There are pulmonologists involved, oncologists involved, critical care folks involved. There runs the whole gamut. And so the goals in creating a management plan for these patients is that we identify those who have a malignant pulmonary nodule, and they can proceed with resection, because ultimately, the earlier we can catch these patients, the best chance for survival they have. 5-year survival for stage 1 treated lung cancer is about 55 to 70%. But the more advanced the stage is, such as stage 3, 5-year survival, it drops pretty significantly down to 5 to 25%. Our other goal is to avoid useless surgery of benign nodules, and so there are different radiologic treatment algorithms or surveillance algorithms, if you will, that will try to determine if these are really benign or not. We also want to decrease any risk that we have to the patient, because anything we do to these patients does have a inherent risk. Even if we send a patient off to have a biopsy, a CT-guided biopsy, they do have a risk of hemothorax, pneumothorax. So it isn't all just very benign. And then we also really want to decrease the cost of care. So to start off, if somebody does have a lung nodule that's identified as an incidental finding, you will see the radiologist make a remark either in the impression, and you may see them actually make further recommendations that the patient needs to have follow-up. So the FLEISCHNER Society is a radiologic society that developed guidelines for these lung nodules in an effort to predict who needed more frequent follow-up and if they needed CT scans or x-rays, or if they didn't need anything at all. And so they came up with different guidelines based on size as well as patient's risk factor. More recently, they updated their guidelines to include subsolid nodules, like we talked about with partly solid and ground glass opacities that hadn't been during their original development of the guidelines in 2005. So there have been some changes. This also just demonstrates that with the subsolid nodules, if they're transient over a course of 3 to 6 months, then chances are that it's just that, it's transient, whether it be related to an infection or just a random appearance on the chest CT. But if it is persistent over the course of 3 to 6 months, that is something definitely to consider, and it goes further into the algorithm at that point. So in order to assess whether somebody has a high risk, a low risk, or an intermediate risk, again, I think we all in the back of our heads, without even knowing it, try to size up whether a patient is a high risk candidate or a low risk candidate. Are they symptomatic? And if they are, I think we all have to presume that it's malignant until we prove completely out without a doubt otherwise. Age. Primary lung cancers are really unlikely in patients less than 40. There are always, you know, the random occurrence or the person that doesn't necessarily follow textbook, but chances are it's pretty unlikely. Also, their smoking status. There's a 3.5 times increased risk for smokers, and it is proportional to the pack year smoked. So also in the National Lung Screening Trial, that evaluated high-risk patients in that group were patients 55 to 70 years old, excuse me, who had about a 30 pack year history and that had end or quit within the last 15 years. If they had quit more than 15 years ago, then it basically set them back to as if they hadn't smoked prior. Drug history, have they been on immunosuppressants? Travel history, any sort of extrapulmonary malignancy. And I think this last item here that's bolded in red is probably the most important one. Have they had any other nodules on previous radiologic exams that we can compare it to? So in a pulmonology review, pulmonary nodule review, I think this diagram lays it out pretty well for us, including different patient factors, but it also includes radiologic risk factors here. So with a probability of cancer, if patients are at a very low risk, you know, maybe they would just need a serial CT scan. However, if they're in this intermediate risk category, then further diagnostic testing would be appropriate, whether it be a PET scan or some form of a biopsy. And then a high-risk category, those with greater than 65% of risk factors, they probably would actually proceed with surgical resection because their risk of cancer would be so high. No further evaluation would be necessary if the nodule were stable for a prolonged period of time. And a prolonged period of time, in my reading in this, seemed to be around 2 years for the small pulmonary nodule that was about less than 5 millimeters. Anything greater than that, a prolonged period of time would be anywhere between 3 and 5 years. I think people would agree also that no further evaluation would be necessary if the patient refused further treatment if it were to be cancer, and also if the patient weren't really a candidate for additional therapy. Different risk prediction models have developed, because we can't just necessarily say, oh, well, I think this patient might be high risk, or I think this patient might be low risk. So different risk prediction models have been developed by Mayo Clinic and Brock University models, and these actually have been proven in validity studies to be fairly accurate in determining whether an incidental nodule is malignant or not. Each of these do take into account several different independent risk factors. Both of these are very, very similar. The Mayo Clinic model does look at whether the person is a smoker, their age. It also includes the radiologic imaging studies, whether or not the nodule is spiculated, the size of it, and whether or not it's in the upper lobe. But the Brock University model then takes into account the patient's family history, their other medical comorbidities such as emphysema, and then also the nodule count and specifically the nodule type. And I think the difference is really just in the year and the time that these two were developed. So the ACCP guidelines basically looked at all of these different studies and all of these different clinical reviews and tried to really put it together for different clinicians in order to guide us in management of our patients. So they had a more recent update in 2013, and the key lessons were to, that workup should correlate with malignancy risk. So all of that risk prediction model with the Mayo Clinic and the Brock University model, that all is taken into account on top of what the radiologic imaging study shows. Literature, unfortunately, still lacks quality evidence on nodule evaluation. And also that it's crucial to include patient preference in the decision making. Do they want treatment further, or are they not even a candidate for further treatment? And it was able to develop recommendations based on the different nodule categories, like we talked about with a subsolid versus a solid nodule. And it categorizes different algorithm, treatment, and surveillance management options based on both the size and the character of the nodule. So just to briefly go over, if you have somebody with a subsolid pulmonary nodule, they're going to separate it out into the appearance and also the number of nodules that are identified on the CT scan. If it's a pure ground glass nodule, based on the size, it's going to suggest different follow-up methods. If it's a really small ground glass nodule, the chances of that having a malignancy in it are pretty low, and so no CT follow-up is required. However, if the size is on the larger size, there will be an initial follow-up at 3 months to confirm whether it's persistent or not. And then if it is, annual surveillance with chest CT for at least 3 years. Any sort of part solid nodule, pretty much similar to the ground glass nodule at a larger size. And then multiple nodules are suggestive that it could be a slightly higher risk. And so each nodule would need to be assessed individually. For the solitary pulmonary nodule that is small, it also takes into account the different risk factors that we've gone over for lung cancer and the different risk predictive models. It then categorizes those patients into the size criteria, and then whether or not you're going to follow up with repeat surveillance CT scans. And lastly, for those solid pulmonary nodules that are more sizable, 8 to 30 millimeters in diameter, again, you're going to go through the same sort of algorithm, assessing their risk factor, and then based on that, determine whether they just need surveillance CT scans, whether they need something a little more aggressive with a PET scan to evaluate whether or not there's any uptake in the nodule itself, or if there's potentially any extrathoracic disease, or if there's a high probability that this patient's larger lung nodule if the patient is at higher risk with a sizable lung nodule, then they may have a standard staging evaluation like we do in the thoracic surgery office and actually just proceed with surgical intervention at that point. So in terms of trying to obtain a tissue diagnosis, there are several different ways. Pulmonologists are able to do some of these, radiologists are able to do some of these, and thoracic surgeons are able to do some of these, although I should be saying we're able to do all of them. They can look at sputum cytology, bronchoscopy, endobronchial ultrasound with transbronchial needle biopsies. This is really only going to be effective, however, if the nodule is central. If the nodule is more peripheral, you might want to refer somebody to interventional radiology in order for them to do a percutaneous biopsy of a peripheral lesion. And then ultimately, the thoracic surgeon can be involved with a surgical biopsy via VATS, a mini thoracotomy, or a standard thoracotomy. So I did want to include this trade-off of evaluation, really to say, you know, with each mode of management that we have, there are goods and bads to everything. And I think it's important that we present these positives and negatives, or advantages and disadvantages, to the patients, because making sure that they are understanding and aware of what exactly is going on, I think, is really important for their overall management and the relationship between the patient and the treater, the physician. But with immediate resection, the positives of that are that you have a definitive diagnosis, hopefully right then and there, and you can treat the patient in a single step. However, we may not necessarily have a definitive diagnosis at that time, and so you do have to let the patient know that we may be taking out your entire right upper lobe and it might be benign. And so they need to be aware of that and be okay with that. The physical complications, we have to let them know that there are risks of every procedure that we have, including death, and it is fairly low, but it is a possibility. For those that do undergo a non-surgical biopsy, the positives of that are that there's a potential for a definitive diagnosis with much less risk than would be posed with a surgical intervention. However, the disadvantages is that it's not always diagnostic. There might be a percutaneous biopsy that comes back without a definitive diagnosis at all. And there are associated complications such as bleeding, pneumothorax, and chest tube placement potentially. And then we have active surveillance, whether or not somebody just undergoes serial CT scans every 3 months, every 6 months, every year. The advantages is that it's not invasive. They can basically just walk in, have a CT scan, have it reviewed by whether it be a pulmonologist or a thoracic surgeon. However, the disadvantages of that are that there is a potential delay in cancer diagnosis and treatment. There may be an interval enlargement over the course of a year, and there may be potentially, if it's an aggressive cancer, increasing of the stage. There is a significant radiation exposure to different low-dose CT scans. In my reading and studies, I believe it's about 15, it's equivalent, one low-dose CT scan is about equivalent to 15 chest x-rays. And there's also this prolonged uncertainty that that these patients can have hanging over their head for some time. So we have these algorithms of how to manage incidental pulmonary nodules, guidelines to go over, and how do we do with that as physicians? This article that was recently published looked at whether the radiology report had any effect on how patients are managed. And it basically, the take home of this was that even when follow-up recommendations are explicitly stated in a radiology report, follow-up for these patients actually remains quite poor. If the nodule follow-up is recommended, actually stated in a radiology report, please have this patient be scanned, whether it be with a low-dose CT scan or whatever, in 3 to 6 months, the follow-up for these patients is quite poor, only 29%. That's if the nodule is in both the impression and the findings. It's a little bit better, but really not that much. The follow-up is still less than 50%. Granted, incidental pulmonary nodules have a very low risk of, by and large, of having a malignancy, but that's potentially a handful of possible malignant lung nodules that are being missed and not followed up. Just to reiterate. And finally, a lot of these guidelines are taking into account the patient awareness and their anxiety levels and their beliefs and knowledge systems about their own pulmonary nodules. And this article had basically sent out a survey to several different patients who ended up being told that they had a lung nodule. And basically the long and the short of it is that most of these subjects grossly overestimated their own actual risk of cancer. So a lot of these patients who were told, yeah, you have a lung nodule, by and large, a majority of them thought that they had cancer. A good amount, about 3/4 of the patients, were unaware that indolent or benign nodules actually existed, that there are pulmonary nodules that people can have that really don't have much of an effect on their overall health or well-being. And about half of the patients did report distress and negative feelings or emotions. So they were being told that they had a lung nodule and basically said, follow up with your primary care doctor in about a month, and so they didn't have any idea of what was going on, and that did cause a significant amount of distress and negative feelings to the patient. So throughout all of this, we have several different providers here, the thoracic surgeon, the clinical oncologist, and the pulmonologist, but I think in reality it does take quite a team to really go through this. I think currently we look at pulmonology as being the gateway to a lot of what we do. They're able to send samples to a pathologist, gets referred back to them, and they are able to then refer patients to an oncologist or a CT surgeon. In the future, however, there have been several different studies looking at biomarkers, whether or not we can assess whether somebody has a malignant pulmonary nodule simply based on either a sputum study or a microarray analysis of a bronchial washing. And so this might drastically change the flow of treatment for patients with molecular testing. Also, I just wanted to bring up different localization techniques. So we are basically dealing with something that is less than a centimeter. And if somebody is requesting us to have some sort of biopsy, whether it be a wedge biopsy or some sort of surgical intervention, it's like trying to honestly find a needle in a haystack. And then we can try to identify where it's going to be on a CT scan and corroborate that with what we see intraoperatively. But if you think about it, on a CT scan, the lungs are completely full of air. when we place a patient in the operating room on single lung ventilation and the lung collapses, it's a completely different ballgame. And so there may be instances where needle localization may prove of benefit. One of these techniques that I read about in more papers that come out of China is a micro coil that's placed much in the same way that a percutaneous biopsy is obtained. And if you aren't able to identify this by palpation in the operating room, fluoroscopy can then be used, so that potentially you may not have to commit the patient to a big thoracotomy incision. The other option that people have been using for localization techniques, again, these aren't exactly mainstream, but borrowed from breast surgery, are radio tracer placements preoperatively within the lung under CT guidance, and intraoperatively then a probe is used to assess for radiation, basically. So with that being said, to summarize, while incidental pulmonary nodules are still a dilemma to practitioners, I think they can be resolved through appropriate workup and surveillance, and I think it's up to us at that point really to identify this on different CT scans and follow through with it. I think ultimately it's really important for us, if we see a patient who has an incidental pulmonology, to really investigate further if this has been present in the past or not. And so if a patient does have CT scans from before, whether it be from a trauma or some sort of pneumonia workup, definitely look into it further and see if this nodule had been present there in the past. If no previous images are available, then determine the size and the type of nodule, and there are multiple guidelines, both radiologic and clinical guidelines, that we can use to follow through and refer these patients to whether or not they need any follow-up at all, or whether they need somebody like a thoracic surgeon to proceed with intervention. As CT screening is for lung cancer is becoming more commonplace, like in the National Lung Screening Trial that makes recommendations, the pool of patients with incidental pulmonary nodules is going to greatly expand, and so I have a feeling that we are going to be seeing a lot more of these sorts of situations. And I think it's very important that we communicate, educate our patients, but also other physicians that are out there. I think primary care physicians have a hard time keeping up with several different guidelines as well in the time allotment they have. So I think a lot of it will be up to us as general surgeons and thoracic surgeons. With that, I will leave it open to questions.